I was asked to talk about recent advances and emerging trends in pulmonology, and as you know, this is a huge topic to talk about within 15 minutes because pulmonology in the last few decades has undergone significant evolution, and it's not just about asthma, COPD or TB alone. So I'll try to cover some relevant things today. In my talk, I will briefly talk about the diagnostic advances in the lung cancer screening. I'll talk about some pleural effusion, current evidence, especially in transudative effusion, and the role of IPCs. And if I have time, then we'll briefly talk about some key features in the current gold guidelines for COPD. So I'll start with with lung cancer, which remains a very relevant topic for us, because this remains the second most common cancer amongst both genders, and there are about 19 million cases every year of lung cancer. And when we look at the survival pathways or graphs for all the cancer sites, we see that the different cancers have made progress in terms of improving survival in the last 50 years. But when it comes to lung cancer, unfortunately, the graph hasn't moved much in the last 50 years, which is a very depressing figure for us as pulmonologists. But number of interventions have been underway and to improve survival in different areas of lung cancer. One of them was to improve the diagnostics. Traditionally, we were getting the tissue confirmation through either endobronchial biopsy or CT-guided biopsy. But the last 2 decades has seen a rapid evolution in diagnostic techniques, especially since the introduction of EBUS TBNA, which has been a game changer in terms of lung cancer diagnostics and staging, which has an implication and impact on the prognosis and survival. So in terms of EBUS, there is linear EBUS, which is used for the confirmation and diagnosis of central tumors and mediastinal lymph node involvement, and along with the staging of the mediastinum in suspected or confirmed lung cancer. Nowadays, the current recommendations are that the patients who have a tumor which is more than 3 centimeters must have a mediastinal lymph node staging through EBUS, because the risk of metastasis is very high. And even in the tumors that are less than 3 centimeters in the lung and they meet certain criteria, then they should also undergo the mediastinal staging, because even in those tumors the risk of metastasis can range from 6 to 30%. So this is a trend that has become a normal practice in Western world, but we are catching up with this technique and tool, and a number of our centers have now started offering this EBUS service. Then there is also a radial EBUS, which is used for the diagnosis and biopsy of the peripheral pulmonary lesions. We have good body of evidence that this technique has good sensitivity and specificity, and this is again a very relevant investigations for us when we are trying to improve survival and catch lung cancer early. So the suspected nodule, which is otherwise hard to reach through CT biopsy, can then be biopsied through this technique, especially in a population where we have such high prevalence of TB, so the nodules could be due to any reason. So that's why it's important in all the suspected cases that we have a biopsy of the nodule, so that if it is cancer, then we treat it early. In addition to improving the diagnostic tools, we also have moved on into molecular testing of the tissue. So traditionally, when the lung cancer was diagnosed as a non-small cell lung cancer, then the tissue would undergo the immunohistochemistry markers to subtype into adeno and squamous cell carcinoma. But we now then have, after immunohistochemistry, we move on to molecular testing, which which assesses the driver mutation, gene expressions, and gene rearrangements. And all these have an impact on the treatment and ultimately the survival of the patient. So we currently in Pakistan, we are offering EGFR testing, ALK rearrangements, PD-L1 expressions, and we know from studies, from evidence, that Asian patients, our patients, have higher incidence of EGFR mutations than as compared to the Caucasian patients. And then obviously knowing this will have implication on the treatment. But the latest in the diagnostics in lung cancer and in tissue testing is the next generation sequencing, which is a technique that decodes a large amount of genome information. And out of the 3 types that are available, the targeted NGS panels are the ones that have the highest accuracy and are cost effective in terms of the Western world. They are cost effective. It still remains an expensive test for us. And it can evaluate about 50 to 100 genes, which gives a very useful information in terms of further subtyping and characterization of the tissue of the cancer type. The biggest advantage of these tests are that in addition to testing on the tissues, this can be done on a blood sample. So for example, the patients where you can't biopsy for one reason or the other, this can be done on a blood sample. So we currently have Foundation 1 panel available, which is not actually tested in Pakistan, but the sample is taken and sent to US, and it comes back in about 3 weeks, and it gives the huge amount of information that otherwise would not be available. So that is the latest trend in the tissue typing and characterization of lung cancer, and all of this is leading to this. So we already have we moved on to targeted treatment. We already have EGFR mutation treatments. We have ROS1 gene expression treatments. We also have got some ALK treatments which are approved. But as you can see from this map, a number of medications are in different phases of clinical trials. So in the next few years, we will see more and more medications coming into the market and leading to the precision and targeted treatment for lung cancer, which will hopefully improve the survival of these patients. And one of the very important tools in improving lung cancer survival is the introduction of the lung cancer screening. So a number of Western countries have now adopted this strategy. So the lung cancer screening, we have evidence from large US, UK, and European trials that it reduces the mortality about 20% in lung cancer. And this meta-analysis, I think this was published back in 2021, included 9 randomized controlled trials that used low-dose CT scan for the lung cancer screening and showed a 16% relative reduction in lung cancer mortality, which is big. Which patients are currently being screened? So the criteria is that anybody aged between 50 to 80 years and has a smoking history of 20 pack years or have quit within the last 15 years and otherwise asymptomatic and in general good health should be offered lung cancer screening. We are one of the pioneers for the lung cancer screening project in Pakistan. In Shifa International Hospital, we've started a lung cancer screening program. We modified the age criteria according to our population dynamics and demographics. So what we are doing is anybody that is between 45 to 70 years and has the same smoking criteria, otherwise general health criteria, is being offered a screening. And once they have stopped smoking for more than 15 years, then this screening can stop. This is just our screening campaign, which we are running, the awareness campaign. So that's a very brief tour of what we are seeing currently in the lung cancer medicine and the diagnostics and screening and treatment trends. I'll briefly talk about pleural effusion. We know that the transudative effusion is a problem that is faced by all the medical specialties. It is a common problem. in majority of them, as you are already treating with diuretics and they respond to these diuretics, but there are a proportion of these patients that will not respond to diuretics and require a pleural drainage, and we know that the heart failure is the leading cause of such effusions, but liver and renal failure also contribute to these effusions, and as I said, first line management remains diuresis to improve their dyspnea. But then high-dose diuretics have their own problems, which and not tolerated by some patients. So these patients then typically require repeated therapeutic drainage to alleviate their breathlessness. So we call these transfusions refractory transfusions, which are not otherwise responding to medications and requiring invasive procedures. Generally, these patients have a poor prognosis with a shortened median interval than actually from the primary pleural malignancies. So we know that from malignant pleural effusions, the indwelling pleural catheters have been an effective tool to reduce dyspnea and reduce the number of pleural interventions that these patients require. There is some observational data that suggests that these IPCs can have a role in the management of non-malignant or transudative effusions. So I wanted to share this trial, which was published in 2022 actually, which was the REDUCE trial. It was the first trial, a randomized trial, that evaluated the use of IPCs in transudative effusions, the problem that we all face. And it showed that the IPCs did not offer any greater control on breathlessness than the traditional repeated therapeutic drainage, despite there was different in the drainage volumes. It also showed that the repeated therapeutic drainage had fewer complications as compared to IPCs, and maintained albumin levels better than with the IPC. But as expected, I mean, patients who were managed with IPCs had a need for less or infrequent pleural procedures, especially those patients who are on long-term anticoagulation therapy, and it's very cumbersome to hold their anticoagulation for repeated drainage. So they concluded that the patient preference and circumstances obviously should play a role in choosing the IPC for transudative effusion. And that this intervention may have a role in selected patients who are having difficulty attending hospital again and again, or who are on anticoagulation and they don't want to, you don't want to repeatedly interrupt that anticoagulation, or who do not tolerate the repeated procedures. So the IPC may have a role, and this is an area that we are currently exploring. So that's mainly about pleural effusion that I wanted to share. And in terms of the COPD recent advances, I believe you've had a very good session yesterday on COPD. So I'll speak very briefly about the key things in the current gold guidelines. So COPD nowadays is not just smoking-related disease. So the current phenotyping categorizes into different causes that lead to COPD. So it could be genetically determined, or could be due to abnormal lung development early in the age, or could be environmental infections, or an unknown cause. And these, and we may see in future treatment strategies that are decided by the phenotypes. But the important takeaway from the current GOAT guidelines was this, that the overlap syndrome, as we used to call them, that term does not exist anymore. So the current evidence suggests that yes, these are two different disorders. They may coexist, but we do not label them as overlap syndrome. So the current guidelines recommend that if they are coexisting, then the therapy should follow the asthma therapy instead of following the COPD line. The other important takeaway from the current GOLD guidelines was the assessment and categorization of these COPD patients. So once we have confirmed the airflow obstruction, we know that there is an obstructive airway disease. We are supposed to categorize the severity of the airflow obstruction and then assess their risk of exacerbation and symptoms through a COPD assessment tool and their exacerbation history. And then patients are categorized into 3 categories. Previously they were A, B, C, D categories, but now they are only 3 categories, which is A, B, and E. And obviously these has an implication on how you treat them. So the patients who are in group A or A category only require a bronchodilator, but in the patients that are in group B or group E require a dual bronchodilators, LABA-LAMA combination. And the other important takeaway is this, that the triple therapy that is so commonly prescribed is only recommended now if there is a peripheral blood eosinophilia of more than 300. Otherwise, the group E should also be managed with LABA-LAMA therapy. And then patients, obviously, as we do, follow them, and if dyspnea remains their main problem, then we can escalate them from a single bronchodilator to a dual bronchodilator, obviously after checking their technique and compliance and all that. But if the exacerbations remain a major problem and there is an evidence of eosinophilia, then we move to triple therapy. But if there is no evidence of eosinophilia, then either a PD4 inhibitor or long-term azithromycin as a therapy. I think that brings me to the end of my allotted time and my talk. Thank you very much. I'll be happy to take questions.